Good evening, everyone, and welcome back to our Breaking Down Barriers to Care webinar series and the continuation of the topic Dr. Hendler spoke about a few weeks ago, what you need to know about treating older adult patients. My name is Adam, and I'm happy to be back with everyone tonight as your moderator. We highly encourage questions throughout the webinar. No question is a bad question. Please ask them in the Q&A section. All right, glad to have you back, Dr. Hendler. Looking forward to part 2.
Okay, I am back. Welcome back, everybody who attended the first one. And there were a couple, before I get started, there were just a couple of questions that came as comments after the first webinar. And the first was explaining to patients that have Medicare Advantage that it doesn't cover 100%. And that discussion is just the same as anybody else who has dental insurance, and just explain that what dental insurance is and what it covers. And but people think that even with regular dental insurance that it completely covers. The other question had to do with what do you do about water in the mouth in older adults? And I wasn't sure whether that was saliva or actual water. So two things. One is there is an issue sometimes with saliva where people don't like to swallow. And there it's just a matter of more suction. The thing that I would recommend is that our operatories don't have spit bowls, and the old office did, and it created a problem because people like to spit, especially older adults, and it would take 10 minutes off the time because they'd want to sit up and spit. So I think the answer there is just a lot of suction. If it's water from like the air water syringe that you're squirting in there and they don't swallow, then you could just back off on that, would be what I would recommend. All right, so let's okay, so in my disclosure here, the objectives, strategies for treating root caries, address restorative challenges, and then I'll throw in some helpful hints of just things that I've come across just from doing this for a while. So the biggest challenges that you will face in treating older adults is dry mouth and root caries. And that's something that I see every single day. The patient comes in, they have root caries or there's a dry mouth. So we'll chat about that. And just to start, so this was a case that came in. This was a woman who, 86 years old, she was extremely frail, but she was in charge. She had a care provider that she would boss around, say exactly what she wanted. And she came in and said, I want to keep all my teeth. And you can see what's going on here. There's just a lot of root decay. And I listened to her and came up with a plan and told her, I said, look, I'm not sure about this, but what happened was we were able to restore most of them. She lost, well, these roots here, and then she actually broke 3 and 4, which I was surprised because there were others that seemed to be in worse condition. But the rest of it was restored. I did make her a maxillary acrylic partial, and she kept the remaining teeth until she died with the partial, and she was very happy about it. So it can be done. You just sort of have to think outside a little bit. So dry mouth, there's xerostomia and there's salivary gland hypofunction. And xerostomia is subjective. So you ask the patient, is your mouth dry? And they tell you. If you want to get an idea, you could say, how often does it feel dry? You can give them a visual scale if you're that kind of person where you want to know more specific. And then there's salivary gland hypofunction, where there's actually a problem with the gland. And that you can measure by spitting into a cup with stimulated and unstimulated saliva. I can tell you from a practical standpoint, from a clinical standpoint, all I care about is if they tell me they're dry. And even if I don't think they're that dry, but if somebody tells me they're dry, then I'm going to automatically start thinking out, okay, they're at high risk for decay because they're going to start putting things in their mouth to relieve the discomfort, even if it's perceived. And usually that's hard candies, cough drops, peppermints, things like that, and that leads to decay. So I'm going to treat them the way I would treat anybody with a dry mouth. The most common cause of dry mouth is medication side effects. And there are over, last I checked, over 750 medications that list dry mouth as a side effect. There can also be autoimmune diseases. Radiation to head and neck is a biggie for dry mouth, and diabetes. And the problem with dry mouth is that saliva has a lot of important functions. And it's also, dry mouth is uncomfortable. So as I mentioned before, people want relief. So they tend to suck on hard candies, peppermints. The thing that always gets me are the people that say, well, my throat's a little dry, so I suck on cough drops. And they think that's okay because, you know, cough drops is medicine. Or lozenges. That's like a great one because it just sounds like it's going to be really comfortable. But the problem is they all have sugar in them, as you know, and cough drops are just more expensive sucking candies because you're going to pay more for a bag of cough drops than you are for a bag of peppermints. But they all have sugar. You end up bathing the teeth in sugar. You don't have the protective features of saliva. And also with older adults, now gingival recession is not a normal part of aging, but you are more likely to see recession in older adults. And with the exposed root, the dry mouth, the sugar exposure, root caries just comes up and it goes really, really quickly. Within a matter of months, sometimes I'll see nothing to teeth breaking off. And the problems with dry mouth, as I mentioned, there's increased caries. There's also difficulties with speech because if your tongue's getting stuck to the roof of your mouth, it doesn't move as freely. Problems with chewing and swallowing, there's altered taste. There's an impact on dentures because you really need that saliva to form a little film to make the dentures fit well. And the impact on quality of life is huge, especially in patients that received head and neck radiation that are dry. I'll see a lot of patients that come in and that's their main complaint, is their mouth's dry, they're uncomfortable all the time and they don't know what to do about it. So what I tell them is the simplest thing is to sip on water and just carry a water bottle with you. And another suggestion with the water is if you carry your own water bottle, then you could put tap water in, which is more likely to be fluoridated. A lot of the water, the spring water and things that you buy from the grocery store may not be fluoridated. So it's just, you know, it's better because you don't have all the plastic bottles. You can reuse the bottle, but also there may be a benefit of some fluoride in it. There are saliva substitutes, there are all oral lubricants, and it's personal preference. I find some people swear by one product and others, they say don't do anything. Personally, I like the oral lubricants, like the Oral Balance, because it tends to stick around longer and people report good relief with it. You could also put it in dentures. I had a hygienist that used to say, and it's true, that she would, if she wanted to lubricate a mouth, she can use KY jelly, but sometimes you get a weird response from the patient if you tell them to put that in their mouth. There are medications to treat dry mouth, pilocarpine and civaline. I can tell you personally that for my older adult patients, I've never prescribed those because I like to treat things at the source. And also, everything comes with side effects. So they're already taking a bunch of medications, and now you're going to introduce more medications that have its own side effects. And sometimes that's worse than the treatment. So I tend to try and avoid giving systemic medication and treat things locally. Fluoride, absolutely. Xylitol is the sweetener we want if they're going to be chewing gum or using mints. And then if they like mouthwash, alcohol-free, because alcohol is going to dry them out more. These are just some companies that make really good products. Biotene, Mighty Flow products, they're local here, coming from Augusta. They make a whole line of products that taste pretty good. Spry makes mints. There's Trident, there's Epic. Xylamelts people really like. So these are just different products that are over the counter that we recommend for patients to try. So the result of all this is root decay. And root decay, as I mentioned, it's more common in older adults because they're more likely to have dry mouth and gingival recession. Now, it's nice if you can find out why they have the root decay. And that just means asking a lot of questions. When somebody comes in, and we talked about risk assessment a little bit last time, and if somebody comes in with a mouthful of decay, they're at high risk. And it's nice to know what's going on. Is it something that you can change? I had a patient that came in with all this root decay, and we start talking, and he tells me that he goes to bed every night with graham crackers in his mouth. Well, that's not good, right? So we convinced him that he shouldn't go to sleep with graham crackers. He should clean his mouth, and that should be the last thing he should do, and then go to sleep. And we really were able to decrease the root decay. I will tell you that you need to look for it. It's sometimes, especially in the early phases, it's really difficult to find. A lot of times it's interproximal, it could be under crown margins, and you could miss it clinically even if you're looking for it. So that leads to more frequent radiographs. you definitely want bite wings on individuals that are high risk for root decay, because you want to catch it early. Because like I said, within a matter of months, it could really go into a big problem where teeth are breaking off. So there are a number of treatment options for root decay. And here's just a classic example. And you could see lots of root decay here. One of them a little bit too far gone where the tooth actually broke off. So one option is, if it's extensive, you can take the tooth out. Another option is glass ionomer, which really works well. And what I like about glass ionomer is the fluoride release. And I use a pure glass ionomer. It's not light cured, so there's maximal fluoride release. And we'll talk about some techniques on how to apply it. You can use composite. Glass ionomers do come in shades now, but the aesthetics are not great. They're not bad, especially on the root surface. But if you need something to really look nice, you can do composite. But again, you're not going to get the fluoride release. But then you can sort of take the best of both worlds and use the sandwich technique, where you could put the glass ionomer in at the deep level and then layer composite over the top of it, so that you have the benefits of fluoride and you have the aesthetics of composite. Amalgam is something that I personally could not practice without. And I know some people are trying to move away from it, but I can tell you that in a lot of the patients that I see, they're coming from nursing facilities. The oral hygiene is basically non-existent. The gingiva is really red, inflamed. If you look at it sideways, it starts to bleed. And they're difficult, sometimes impossible cases to isolate. And I know that if I get mechanical retention, I can get the amalgam to stay in there. And also from the other standpoint of dealing with uncooperative patients, for composite, you need some cooperation. You have to be able to maintain the field reasonably dry. And if an individual has late stage dementia and they're moving around and the gums are bleeding, you never know when they may move. And if I'm in the middle of condensing amalgam and they start to move, I can blow out the saliva, the blood that got in there, and carry on. And I feel comfortable that I can still have a successful restoration. SDF, hoping everybody is familiar with this product, and I'm going to speak more about it in a minute, but that stands for silver diamine fluoride. And it's been a huge benefit to geriatric dentistry, to pediatric dentistry, to palliative care dentistry, and I'll show you some examples. There's always the option of doing nothing. Now, you know, as healthcare providers, sometimes that's really hard to do nothing, but you talk to the patient, and sometimes, you know, if they understand the consequences of their decision, I'm not going to force people into treatment. And especially in a lot of palliative care cases where they just don't want to undergo the treatment, or they can't tolerate the treatment, they're comfortable, they're eating, and then that's the optimum. Basically, prevention, like with everything, is always best. It's going to be more successful to prevent root caries than to have to catch up and treat it later. A problem that I see a lot is, what do you do with the wraparound root decay? So you excavate the decay and you end up with a situation like this. And these are difficult to restore. They're big problems. And amalgam is hard to condense because you push it in one side, it comes out the other side. Filling them with composites, sometimes difficult because it's a long, involved procedure. And one little tip that I came up with years ago that I'll pass on that I like is, one surface restorations are really easy. So what I decided, or what I did, was I took a Tafelmeyer and cut a hole in it. This seals off the interproximal areas. And now in this case, I could just put my material in, and the only thing left to restore is the buccal surface, because if you get the retainer on really well, then the contours are good, the interproximal is good. And in this case, this was years ago, I did amalgam, and it works out really well. There's minimal to restore, and it stays isolated. And you can do that with bulk fill composites, glass ionomers. It's just a really good way to hold the restoration in place. Now, another tip that I do a lot, and I just took pictures on a dentiform, is especially for lower anteriors when you have interproximal root decay. So I excavate the decay, and the problem is, well, how do I pack it in, especially with a patient that may be difficult or where there's a lot of gingival bleeding. So what I will do is take an extra large Mylar strip and just run it through both embrasures. And then I just fill the whole area up with glass ionomer, And then you could see I just have my fingers and I squeeze the band tight. And if you look on the lingual surface, you can see when you pull it tight, there's pointers over here somewhere. When you pull it tight, you really have good, it's tight against the tooth, tight against the root surface, and it gives you good contour. So again, after it's set, and you have to hold this for a few minutes for the glass ionomer to set, but after it's set, you're basically just left with this excess on the buccal that becomes really easy to trim back, polish, and you are done with the restoration. And there it was. Now, a lot of older adults come in, they've got a lot of big fillings, and there's a lot of recurrent secondary decay. And over the years, I would just go in and try and repair things if I could, especially on patients with late stage dementia. They were difficult to treat. And I figured, well, this is the easiest. So it was really nice to have a study that sort of verifies what you've been doing. And this study came out in 2015, and it was about repairing or replacing restorations. And what they found, one, which is obvious, that a repaired restoration is going to be more conservative and it's going to require less time because you're just going in after the decay. But the big thing was that if the defective restoration had been repaired, it was less likely to need an aggressive treatment such as replacement or endo or extraction than if it had been replaced. So you really can put fillings on top of fillings, and the material, it's based on what your preference is at and what the situation is. I've done repairs with composite, glass ionomer, amalgam. They all work, and it's just a much easier, quicker restoration, and they do last as long as the existing restoration was sound. Now, sometimes you get in there and everything falls apart, and then you're sort of stuck. But the vast majority of the time I can get in, just excavate the decay, and then fill it, and I'm done. Another situation is you saw the Panorex I showed you in the beginning, and there is extensive decay on those teeth. You saw that. And one thing is to worry about, well, if I excavate this decay, I'm going to pulp the tooth. And yeah, that happens sometimes, although the other advantage is pulps do recede as people get older. So you really can tolerate a much bigger cavity, much more decay before you hit the pulp. But there's still the situation where endo may not be an option and you're excavating it and you don't want to extract the tooth, and what do you do? So in school, we would learn about direct pulp caps and indirect pulp caps, and I would tend to excavate down, and here was just a good study that looked at this. And what they found was that if they leave some decay, and they did different treatments here, like one step where they just put in the definitive restoration, and then there were also two-step restorations where you go back in. I do one step. I can't think if maybe I've gone back in over time, but that you basically take out most of the decay. And what they found was that it reduced the risk for pulpal exposure and pulpal symptoms, which seems obvious because you're going to stop before you get there. But they also found that incomplete caries removal was advantageous compared to complete excavation in proximity to the pulp. And you ended up with less pulpal problems later. And I could tell you that it works out really well. You just want to make sure that you really seal the restoration around the margins. I'm going to take a pause here just to see this question. What do you use to cut a hole in the Tafelmeyer band? And I just take the burr in the handpiece and put the band in the holder and then cut the hole, because you want to make sure that you get that facing forward and you don't extend too far around the sides. But you do have to make sure the hole is big enough so that you can get the condenser or whatever you're squirting the material in with. So that was the only thing I ran into problems in the beginning. All right, and then there's another study that came out in the Journal of the American Dental Association, was evidence-based clinical practice guideline on non-restorative treatment for carious lesions. And what was interesting here, the one that stands out to me is the 38% SDF. And they're using it as a treatment for decay with and without cavitation. So let's move into that. So what is silver diamine fluoride? It's a high concentration of fluoride combined with silver. So the silver blocks the dentinal tubules, it's antimicrobial, and the fluoride has a remineralization properties. And it was originally approved in this country for sensitivity, I think back in 2014, but we knew it'd been around in Europe for a lot of years and in Japan for a lot of years, and we knew that it would arrest decay. So that was my primary reason. Once it was approved, we were able to get it in this country. And from the beginning, pretty much I was using it for arresting caries. And the big one in this country is called Advantage Silver Arrest from Elevate Oral Care. And I think that's the only one that I'm familiar with of silver diamine fluoride here. We use it in individuals that are at high caries risk, people that have behavior challenges, and this is where, and notice that, so I'm talking about geriatrics, and notice these guidelines down here are coming from the American Academy of Pediatric Dentistry recommendations. So it's really similar. People with behavior challenges, medical challenges, if they've got a whole mouthful of root decay that you plan on restoring, but you know it's going to take a while to get to it, you just treat them with silver diamine fluoride. You can arrest the decay, it buys you time. It works wonderful in areas that are difficult to get, under crown margins, especially if you catch it early. You can treat it with silver diamine, arrest the caries that are starting, and sometimes you're done with that. Patients without access to dental care, this is good from a public health standpoint. And then if there's active caries without pulp involvement, you can use it. And as it was mentioned, it's an alternative to restorative treatment. As opposed to putting in a restoration, you can use the silver diamine fluoride and that's your treatment. Around margins of lesions, we talked a little about that. It's wonderful for root caries, for prevention and arrest. We use it a lot for prevention and we use it a lot to arrest decay. To avoid surgery, if the person's not a good candidate, or if you know that in order to do an extraction or multiple extractions, you're going to have to take them to the operating room, and you really don't want to do that with older adults, especially frail older adults, because as we mentioned before, they're not going to have good outcomes. So is there something that we can do to just preserve the tooth to avoid that? And that goes with the avoiding general anesthesia. It's wonderful in palliative care. Individuals end of life on hospice, they break a tooth, and I'll show you some examples of that. You can use it as a liner, and the thing to know about it is that it turns the area black, and I'll show you examples of that. So here's an individual that just broke off a tooth. It was completely asymptomatic, and they didn't want the extraction. They were comfortable. So I just put some silver diamine fluoride in it. You could see how it turned it all black. The gingiva around it looks fine. And they just kept it. They didn't have a problem. And I explained, they understand that if they have a problem, we would have to take that tooth out. Let's see. Any suggestions on how to remove a tooth on minimally cooperative patients from a patient management point of view? Sometimes those are difficult. I mean, if you have and this is where the silver diamine comes in handy. So if it's really an uncooperative person, you know, I like sometimes just oral sedation, something, a diazepam, a Valium type drug. I like Ativan or Xanax, you know, something short acting. And I will use that. A lot of times, as I spoke about before, is you can just talk the patient through the procedure. But if you can't do it, then if they're comfortable, a lot of times I'll avoid the extraction and just do some things to keep the tooth comfortable. Let's see what else we got here. Okay, so we got that. All right, moving on here. So here's another case. This was an individual with late stage dementia. And you could see, you know, this amalgam was done years earlier. The patient was more cooperative. And you could see the extent of the root decay here. And when I say use it as a definitive restoration, you could see the tooth is decayed, but it still sort of has the contour. There's not a huge cavitation. And I just painted silver diamine fluoride on these, explained to his wife it was going to turn the tooth dark, but this was the definitive restoration. And that hardened the tooth, and we were able to maintain that tooth. The way to use it, as I mentioned before, it's really important that you tell the patient or the care providers that it's going to turn the area dark. But the advantages to me on the patients that I'm using it for outweigh the disadvantage of it being dark. You do not need to remove the caries. but you want to get off all the debris. So if there's a lot of plaque and food debris, then at least get rid of that so that you see the decay. Isolate the tooth, dry it, and then just take it. It'll come with a, you put a drop in a dappen dish, take a micro brush, paint it over, and allow it to sit for a full minute at least. They recommend 1 to 3 minutes, but you want to keep it on there undisturbed for at least a minute. And then when you're done, you could blot off excess, you could rinse it off, and that's it. It's done. It takes a little while sometimes to turn black, and you can reapply it if it's not 100%. I mean, it's pretty successful, but if the person's coming back soon anyway, then I like to just check it and just throw another drop on it if I've got it in another couple of weeks if they're coming back anyway. And then I evaluate it at 6 months, and sometimes we'll retreat at 6 months, or definitely every year we'll retreat it. The other thing sometimes we'll do is after we treat it with the silver diamine fluoride is we'll just put fluoride varnish over the top just to get the areas that we didn't use SDF on, and it just sort of helps hold it in there a little. And that's, the problem that I don't like about this is you do a prophy, the teeth are all clean, and then you end up doing this, and this is how you send them home. But again, it's a huge advantage. So if you want to use it, so I mentioned before that you can use silver diamine fluoride as a liner. And basically there you go in, and sometimes I'll remove, a little bit of the top of the decay, so I'll have room for a restorative material. And then I treat the tooth, as I mentioned before, isolate it, rinse off the excess, and then I like to just put glass ionomer on top of it if I want the aesthetics to be better. You can also bond composite to the top of it, and that works also. The important thing though is once if you light cure the silver diamine after you put it in there, it turns black immediately because the silver oxidizes. And even if it's not decayed surface, it turns black. Now that part you can polish off, but then it's really hard to restore the tooth after. So if you can just treat it, get the glass ionomer on, and it's not going to be a perfect, beautiful restoration. If you have opaque composite, you can block it out better. But that's what I do. And the aesthetics are not that bad. It works out pretty well. As far as coding it, there are codes. The code we used most of the time was D1354. It is a per tooth and a per surface code. And then I think last year, 2021, they introduced the D1355 code, which was application of a caries preventive medicament. And I think this one may be questioned recently. But again, that's also a per tooth and per surface code. So here's another individual that I treated. Actually, no, I didn't. I just wanted to point this out because this was a person who came in with late stage dementia, and you could see similar to the person who I showed you originally, the Panorex, and the full mouth series. And again, lots of decay. The plan was to basically do exactly what I said. I was going to treat him with silver diamine fluoride and then just fill those defects with glass ionomer because it's a quick thing to do, and then hopefully maintain the teeth. Unfortunately, he died within a couple of months of this exam, so he ended up not having any treatment. All right, what do you think? Before or after treatment? This is the situation. And that was after treatment. So this is before. This was another individual that came in with late stage dementia, difficult patient to work on, mouth full of roots. And the issue here is that this person was comfortable, functioning well, eating whatever they wanted to eat. One treatment plan would have been to take out all these roots and put in a denture, or based on my other talk, put a denture on the top of it. But I didn't know, and I never know, how an individual with late stage dementia is going to tolerate a denture, assuming you could even make it. So I'm thinking, how can I keep this person functioning on what she has? And basically what I did was what you saw, excavate the decay and, down to where I felt comfortable. And some of those I was able to get out the decay, flow glass ionomer in, well, silver diamine fluoride, and then flow glass ionomer in. And the pictures, it was difficult getting pictures of her because she was moving around a lot, but you can see how the darkness still even shows through. And the other thing I wanted to point it out is that there's occlusal contacts here. So she's functioning on these roots, and this served her well for the rest of her life. Another situation that I get is a person comes in and they've got a hopeless tooth. And I know you're all looking at this and saying, don't you mean hopeless teeth? Because they all look hopeless. And yeah, this was how it presented. And once we cleaned it up, then you can sort of see better how there's extensive root decay on the lateral incisor. The other ones are not great. You can also see how the gingiva is pretty inflamed. What I like to do in these situations is a natural tooth bridge. So I bond everything together. And in this case, because there was not a whole lot of root in there, I bonded first, sectioned it, and then removed the root. If you have a lot of root and you have the crown of the tooth, sometimes I can extract the tooth first, cut the root off, and then rebond the tooth in there. And these are really good restorations. Again, you got to have proper patient selection. If they're really heavy bruxer, this isn't going to work. But if they've got, they don't chew hard, they've got really light occlusion on the anterior, and you can get the occlusion off, these are really successful. And I've done lots of these. And that was right after the tooth was extracted. And in this case, I went back later and added more composite after it healed, just for aesthetic reasons. And it looks pretty good, and they were able to function. And doing geriatric dentistry, one of the things what I like about it is it's a challenge. And I always want to know, what else can I do? Can I push the limits on some things? And this was a situation where I sort of did push the limit. They had a natural tooth bridge, and then this tooth developed a radiolucency and a fistula, and I had to get rid of it. So I have two pontics here, everything's bonded together, and that actually served well. She didn't have a lot of occlusion. I think I had to repair it once, but it stayed together. So sometimes you can really push the limits. But again, you don't want somebody who's going to be grinding and biting into apples and hard things on the anterior, because they are just composited. And you can do splints on the back sometimes, but I tend to just use composite just because it's easier for me. So some other stuff, this is just some fun stuff. This is a person who came in. You don't get to see this all the time. They were functioning, we know mandibular dentures are tough. They were functioning on half of a mandibular denture, and they would reline it with cotton every day. And they were functioning on this. Eventually, they agreed to have a complete denture, and I made them a lower complete denture, and they were really happy. They're wondering why they didn't do that before, but that's just an interesting thing. Sometimes patients come in and there's completely calculus crown. It's completely covered in calculus. This was sort of a one-off, and I'll share it with you. It was an individual who had severe dysphasia. They were taking nothing by mouth, but they wanted a partial for aesthetics. And I'm thinking, all right, they had a couple of teeth left. I think they had three or four teeth left, and they were all completely covered in calculus. And my hygienist didn't want to hand scale this. She wanted to use a Cavitron, which I don't blame her, but we didn't want to, they could barely swallow their own saliva. So we didn't want to just blast the Cavitron in there. So I'm thinking, and so this was the other side. And I actually took the picture after I had done a couple of the teeth. But what we did is we isolated the teeth with a rubber dam. And then we were able to use the Cavitron, and tooth's pretty clean. They ended up not getting the partial, but at least they had clean teeth. So, just sort of thinking a little differently. This is something that happens a lot treating older adults, and I think it's important to be aware of. There's a question up here. How are you billing, charging your national? Oh, yeah, that's a tough one. A lot of times what I'll do is I'll bill an extraction, and then I'll bill, sometimes I'll use the splinting code, the external splinting, I'll use that. If there's decay in adjacent teeth and I'm bonding them together, then I could just bill out like restorations on the adjacent teeth, because I'm restoring those too. So it just sort of depends on the situation. But I find that works, because the splint is not usually questioned, and if I'm restoring something, it just happened to be gluing a tooth in at the same time, then that's the code I'll use. So this is a situation where individual late-stage dementia gets a sore in the mouth. And the concern here is that if they're in a nursing facility or they're with a care provider, sometimes you're going to get a phone call that, hey, my mom's not eating anymore. And if they're in a nursing facility, a lot of times the nurses think, okay, we'll look in the mouth, see if there's a problem. But people also think, well, they have no teeth, so they can't be a problem. And they forget, like we all know, dentures have their own set of problems. But the thing I want to point out to be aware of is sometimes a person with late stage dementia can't necessarily tell you, hey, my denture hurts, can you get it adjusted? So what they will sometimes do is, one, they'll stop eating, and then that can alert somebody that, hey, there may be a problem in the mouth. But the other thing is that there'll be behavior changes. And these are not often picked up. And a lot of times it'll just be attributed to the fact that, well, it's a progressive disease, they have dementia, and unfortunately, we're just going through a bigger, a bad phase, and they get treated with medications to control the behavior. So I think it's important to know, and if you know people that are working in nursing facilities, either attendings or nurses, you just say, hey, by the way, I just heard about this. If somebody becomes agitated suddenly, it may just be that there's pain, and it may just be pain in the mouth. And these are great because you adjust the denture and the behavior goes back to baseline, and they start eating and everything heals. So it's a really good treatment. Denture stomatitis, you've seen these. I like to put nystatin cream in the denture because it treats the denture. It also treats the palate. And again, I'm treating it directly at the course. I will tell you that at the source that these do take a long time to resolve sometimes. Medication-related osteonecrosis of the jaw. A lot of older adults are on bisphosphonates. This is a situation where this was an individual who had metastatic breast cancer, and they were receiving IV infusions of Zometa. It's more common there. There are cases, this was an individual taking Fosamax, and she had all these bony exostoses, and she had exposed bone. The important thing to know about this is if a patient questions you, like, I don't want to take this drug because I read the drug insert and it says it's going to cause my jaw bones to die, the benefit for fracture prevention way outweighs the risk of osteonecrosis. It's not even close. We know what happens if an older person falls and breaks a hip. There's a percentage, I forgot what the percentage was exactly, but there's a percentage of older adults who break a hip that will die within the first year. So we want to avoid that. There's just a lot of mortality associated with it. We can deal with this. The other thing that I will tell you is the guidelines now is that people don't stay on bisphosphonates. And I'm going to say anti-resorptive agents. Zometa, Prolia also is included because you can have the same problem, denosumab. So people get drug holidays from those. And this woman here, the drug was DC'd and she ended up healing spontaneously, which was pretty impressive. And if you do need to extract the tooth, you can extract it. You just need to explain to the person that this could happen. But I've had pretty good results. The osteonecrosis and people just taking it for osteoporosis is rare. It doesn't happen all that often. So, but good oral hygiene and PeriGuard helps. So just a review from last time, solutions for challenging cases: treat with respect and dignity, make the patient comfortable, address the chief complaint. Even if you're not going to be addressing it that day, acknowledge it, keep track of your fingers, give options, treatment should be realistic. Don't let age influence treatment. Medical status can influence treatment, and quality of life can override the medical status that influence the treatment, as in palliative care situations. But don't judge people just because of what numbers attached to their age. When you're treating older adults, you want to update the medical history often. That can change overnight. You see a person last week, they come in the next week and things might have changed. So I always like to review the medication list. And a good question to ask is, have you been in the hospital since the last time I saw you? Because a lot of times you're going to get, nothing's changed. Everything's the same. So sometimes you just have to probe a little bit. And I think with any patient, you want to eliminate pain and infection. It's just what you want to do for patients. You want to optimize function from a patient perspective. So as I showed you before, the patient with late stage dementia was functioning on the roots. I didn't need to take them out. I didn't want to take them out. I didn't want to create more problems for myself. So she was able to function on the roots that were there. The aesthetics was not a concern. It was more just the health of her mouth. And it was also easy to keep clean where things were smooth without having the decay. You also don't need to replace all of missing teeth? Is that a new question? Okay, so here's another question. Could you please share some tips on how to introduce a complete denture to a patient with advanced dementia? That is sometimes a hit or miss. Now, if they have a denture already, then sometimes I'll leave it. And then actually, I'm going to talk about that in a minute too. But sometimes it's just difficult. I will avoid at all costs going from natural teeth to a complete denture because I think it's a really big change and it's difficult. And if you take out all of the teeth for an individual, then you're sort of stuck. And if they can't tolerate a denture, you're really stuck. It's if they've got some cognitive impairment but can understand and you can explain, hey, this is going to take a little getting used to, that's the best way. And also I find that, if the person wants a denture, they'll tend to get used to it better than if they don't want one to begin with. I had my learning experience back when I was doing my residency. I made a denture for an individual because the family said dad needed teeth. And dad came in and told me the first appointment that he could eat anything he wants. He didn't want teeth, but he had the best set of ridges. I made him a beautiful set of dentures and, just didn't think about it. Family wants some top dentures. And I made the dentures and he's back the week after. Family wants to know what's wrong with the dentures because he's not wearing them. And it was my fault for not listening to the patient and explaining to the patient, because when you go back and explain afterwards, it seems like you're making excuses. So, and we'll talk more about dentures coming up here. So, okay. You don't need to replace all missing teeth. And this was not my patient. I just found this guy on the web, but he was just like one of my patients where he had one incisor left. And he came in and it was bothering him and it was loose and it had inflammation around it. And I'm thinking you're better off without this tooth. And when I proposed that we just take the tooth out, he's like, oh, no, that's my chewing tooth and you can't take it out. So I cleaned it up and he was very happy. He went on. Yes, it was loose. I'm sure it fell out sometime after I saw him, but that was what he wanted. And he was functioning on that and he was happy. He didn't want anything else. And that addressed his chief complaint and made him happy. Leave occlusal stops when possible, and especially when not replacing teeth. So that just goes back to the case I showed you before. That person was functioning. The other thing that's important about it is that it avoids soft tissue trauma, because I've been in situations where I've had to take out a root and the person was not a candidate for dentures, didn't want dentures, and I run into a situation where there's an opposing tooth and it's constantly biting into the extraction area and it's uncomfortable. And those become more difficult because then you sort of have to try and relieve the areas as they hit into the soft tissue. So if you can leave a root, it's a really good thing to do. And as I mentioned before, don't make dentures for a satisfied patient because they're going to fail. And even if the dentures have problems, because if they think their denture is great and you make a denture that you know is great, it's much better, they're not going to like it because it's not going to fit like the old denture and it doesn't look like the old denture and they're not going to be a satisfied patient. And going back to the dementia situation, the only time, and it's rare that I will make dentures for somebody with late stage dementia. A couple of times I've done it where the patient was able to cooperate a little and they had a denture in the past. And I felt confident that, they had some memory of a denture, but still you've got to tell the family that, and that's assuming you can make the denture. Sometimes it's really difficult to treat these individuals because they're not cooperative. And it's difficult to get impressions. It's difficult to get an accurate bite registration, but assuming you could make the denture, you need to inform the family that there's a chance that the individual will not wear the denture and will take it out. And I see that with patients that come in, the family brings them in, what's wrong with dad's denture? He's not wearing it. Or what's wrong with mom's denture? And there's nothing wrong with the denture. It's just they're at a stage of disease where they don't want anything in their mouth. They can't tolerate it. And they take it out as soon as you put it in. And then you just have to explain to the family that it's not the denture. The person just doesn't want to wear this denture anymore. And, maybe down the road, as the disease progresses, you can put it back in, but they need to understand that. I always do a wax try-in because aesthetics is subjective. And I've had patients look at stuff and say, I did a beautiful setup and they're like, I don't like that. And, they want the teeth I want it like my old denture where the teeth were all flared out. And so if you make it looking really good on your mind, then they're not going to like it. And a very important part that actually I addressed this morning when I was delivering a denture is removable dentures have to be removable. If the patient can't get the denture out, it's not a good restoration. And it's really frustrating as a dentist as you make a beautiful partial and it fits like a glove. It presses in there and it is so stable, but the individual doesn't have the strength or dexterity to get it out. And if somebody's not taking it out, we know we don't want to leave them in all the time. So then I go back and I have to start relieving it so that they can get it in and out. So here's an individual that came in, and this is what they presented with, a couple of broken teeth in the top. And I'm working up the patient. I'm asking him questions. What do they want? Are they uncomfortable? Can they function? So is this a challenging case? Yeah, it could be. But in this case, the person was satisfied. They were functioning on what they had. There was no infection. They weren't concerned about the aesthetics, and they didn't want anything done. So this was not a challenging case. Once I spoke to the patient, it was a simple case, cleaned them up and just put them on routine, and they were doing fine. Solutions, other solutions from cases. I like to modify existing dentures. So if they break a tooth, I always look to see if there's an existing denture that I could modify. This works great because sometimes the patients don't want a new denture. And also if they're a difficult patient to deal with, it's a much simpler treatment. I like to avoid mandibular complete dentures. I like overdenture partials and transitional dentures. If I think that they may need a full denture and I want to avoid it, I'll leave teeth in that are mobile and build over dentures around them for as long as the person can hang on to them. And teeth for special occasions, not just sometimes people just want it for aesthetics and it doesn't, that's all they care about. They're not functioning on them. Let's see, there's some chats here. Let's see, credit upon completed up, blah, blah, blah. Is there an issue with aspiration of loose teeth left in? I have not had that issue, but if something's really floating in the breeze, then I'll take it out. But teeth that are mobile and there's still some bone support, I have not had a problem with it. But again, if there's no bone at all and they're flopping around, then I will take those teeth out. All right, let's see what the Q&A has here. Do you need a power of attorney for treatment of dementia patients? You need somebody to say the treatment's okay. And in my case, somebody has either scheduled an appointment and a care provider is bringing the individual, or the family member's coming, so I can have the discussion with them right away. And I get the consent for the treatment. But you do have to be careful. You don't want to just start providing treatment. Criteria for deciding if a patient, that's a whole lecture in itself if a person can make decisions. And a lot of times, because I'm getting individuals from nursing facilities and people are coming with care providers, I'm fortunate. I'm not in a situation where I'm seeing people that are just coming in. They have access, they're being treated medically, and I'm seeing these individuals. So somebody has authorized the treatment and there's somebody that I can talk to directly. But you do need to have somebody know what's going on before you treat if you don't think that the person is able to make the decisions. And there's social workers, and you always look for family members too. That's usually the best place to go. So this is just your classic overdenture. These work great. And we know about lower dentures. So even if you have one tooth left, and even if it's a loose tooth, that denture is going to be 1,000 times better. Remember that ideal is not necessarily ideal. What we were taught in dental school may not be ideal for that individual. What does the patient want, and what's feasible? What can you accomplish for that individual? We definitely do more frequent cleanings on patients. We're seeing individuals average every 3 to 4 months. We had some patients where the family knew no oral hygiene was being done in the facility, and I remember we had 1 or 2 patients, they would bring their mom or dad in every month for a cleaning because they were really tuned into their oral care and they wanted to be on top of it. And boy, that's an ideal situation because you can really stay on top of things. Topical fluoride, pretty much everybody gets fluoride. And what I like, as I mentioned in the beginning, is creating solutions for problems. And again, treat patients with dignity and respect. I can't emphasize that enough. And prevention is always the best solution, just as dentistry as a whole. And I will mention that electric toothbrushes, we have really good success with those with our older adults, and even for care providers. And we like ones with a full head because they're really easy to use. You just hold it in there and just sort of march it around the arch. They have a timer, so you know you've brushed long enough. And we've seen really good results with that. And the other are the little interdental brushes. Flossing is really difficult. People seem to be fine with poking toothpicks in between their teeth. And my hygienist really stressed these. And I was just amazed at the results that we get and you know, the little things with bristles on the end that you could poke through like a toothbrush, those work wonderful. And fluoride. So prevention is the best solution. We know that. This was just a case where a torus, no ridge. The person had a horseshoe denture. I added a palate and just relined it with a soft reline, and that soft reline acted like a suction cup. And you could see how far back this denture extends. The person tolerated it well. And that was a great, I didn't understand how they tolerate. This woman was 91, and I'm not sure how she was able to function with the denture previously. It was a horseshoe denture, and she came in, her complaint was it was falling out. Another one, challenging case, huge tori, couple of roots. And again, talk to the patient. This guy was satisfied, didn't want anything done. He came in just to have things checked out, and he was happy. This one was just a challenging decision. It was a woman who didn't like her aesthetics. In her 70s, she decided she wanted to do something. So geriatric dentistry is not all just sort of doing root decay. Sometimes you get to do other interesting cases. And the tough thing here, she finally decided to go ahead. Her husband was like, she hung the moon, do whatever you want. And I restored her. This was strictly aesthetics. And she was really happy. Unfortunately, before she made the decision, she developed Alzheimer's disease. She was diagnosed, and she still went ahead with it. And she had a rapid course. But what was really great about her situation is she came back for follow-up after we did completed treatment. And she just said to me, went to church last weekend, and everybody's looking at me and said, you look really good. What'd you do? Did you change your hair? And she's like, nope, got new teeth. And she, from a quality of life standpoint, having those teeth in there was a huge benefit for her. And she really, the last couple of years that she had was really much better for her. And this is one last case I want to talk about. And I bring this up every time I talk. And this was a case that went back to my days as a resident. And this was an individual, he was on the younger side. He was in the nursing facility, and he sustained a closed head injury and lost his front teeth. And they made him this flipper that didn't fit. And the dental director in the nursing facility I was there said, make him a fixed bridge. And you could see his hygiene's horrendous. He had hyperplasia in his palate. He was a behavior problem in the facility. And I thought, well, do we really want to do all this work? Because I figured it's just going to fail. But on the other hand, it was a great teaching case. And I went ahead and I made him a fixed bridge. And I thought it came out pretty good. This was a long time ago. But the thing that stuck in my mind is back when I was doing this residency, I was in nursing homes, and I would attend the interdisciplinary case conferences if I had treated the patient. And the thing that was amazing to me was that all the nurses, the social workers, everybody who took care of him said, after you fixed his teeth, he's just a much nicer person. He's not a problem. He's not behavior problems. He's much easier to deal with, and he's a happier individual. And it just goes to the fact that what we can do as dentists for improving quality of life and improving overall health. Look at his gingiva now. Once I put a temporary in, he got rid of the partial in the top. He started brushing his teeth. Everything, and I ended up doing a lot more treatment on him. Some root canals, we did some surgery to get rid of the hyperplasia in his palate. And it was just a great case, and just, something that we are all capable of doing, and makes a huge difference in people's quality of life. So remember that the mouth is part of the body. So disease in the mouth can influence disease in other parts of the body and impact general health and overall well-being. And let's see. So I'm going to leave you with this. And last talk I gave, someone asked me how I got interested in geriatrics. And I mentioned about Dr. Saul Kamen, who was not only because I received an email from one of the attendees who said he was inspired also. And I could tell you that a lot of people were inspired by Dr. Kamen. And I was just cleaning out some old files the other after the last talk, and I came across this. He sent me a letter because I used him when I was applying to dental school and saying how he was my inspiration. He wrote me a letter of recommendation. And so I thought this sort of sums up how he described geriatric dentistry: more caring than curing, more touching than technology, and more compassion than composite. And a lot of it just says you really want to be tuned into the individual and treat the individual with respect. And you get a lot of stuff done, and it makes a big difference in quality of life and how you feel about yourself too. So on that note, I will leave you with my favorite quote recently is, we don't stop playing because we grow old. We grow old because we stop playing. So I encourage everybody to continue playing. And let's see. So I'm happy to take any questions. My email address is there. I'm happy to stick around.
Cool. Well, I think you answered them all. So we'll wrap a little early here. Thank you so much, Dr. Hendler, for the 2 presentations and for sharing your insights. We truly appreciate your participation and willingness to participate in our series. And thank you, everyone, for attending tonight's webinar. We did record, so we'll get that out to you in the next week. And again, if you do have any CE questions, please email us at webinars@henryschein.com. Thanks, everyone. Have a great night.
Thanks. Good night.